Now, you are a fourth year medical student, is that correct?
Yes, that's correct.
Yes, Doctor, we are.
Right. So I don't mind being interrupted at any time, please. So if any of you has any questions or anything I say is not clear to him, interrupt me and I can spend more time on it. So basically, the disease or the syndromes that we'll talk about, whether nephritic or nephrotic, and from now, nephritic or nephritis, the suffix itis stands for inflammation. So when we talk about nephritic sediment or nephritic syndrome, we're talking about inflammation that affects the kidneys. So nephron means kidneys and itis means inflammation. Osis, for those who speak Arabic, is like tilal. The meaning of it is tilal. It's a syndrome that affects the kidney. The sine qua non of it is basically the kidney will lose its ability to keep protein inside the blood, and with osis, the kidney will start to leak protein in the urine in significant amount, and hence the name osis. So when we talk about itis, inflammation, usually idiopathic, we don't know why patients develop the inflammation in the kidney. And by the way, inflammation is different than infection. Infections means there is invading organism that triggers the inflammatory response that we see. Here, inflammations is simply idiopathic. We like to think it's autoimmune, meaning that the human body will start to form some immune reaction against self, against its own tissue, to cause the inflammation. So this is what we mean when we say nephritic or nephritis. It's inflammation affecting the kidney. Osis, it's like a disease characterized, the most important aspect of it that affect the kidney, that is characterized by significant leakage of protein in the urine, which is something that we don't see normally. The kidney is able to keep all protein inside the blood. Now, it turns out that the component of the kidney that is affected by itis or osis, whatever the syndrome is the glomerulus. As you all know, the kidney is composed of, each kidney is composed of at least 1 million functioning units. It's called nephron. And the nephron, the first part of it, is called the glomerulus. And I'm sure you've studied that at least by now. So the syndromes that we are talking about, whether nephritis or nephrosis, affects this part of the nephron, which is the glomerulus. So exclusively, whatever we're going to talk about today, whether itis, nephritis, glomerulonephritis, or glomerulonephrosis, or nephrotic syndrome, is a disease that affects this part of the nephron. This is how the glomerulus look like under the light microscopy. This is a normal kidney, but just to show you, this is a schema of the glomerulus and what's inside it. As you know, the glomerulus is composed of capillary loops that are tethered together by a matrix called mesangium. And this is the way it looks like under cross-sectional view of a kidney biopsy. This is how the glomerulus look like. Now, I think to understand this in a better way, we're going to tell you what is the disease process that will lead to nephritis or nephrotic syndrome, talking about the histology, and then later on about the clinical presentations and the findings. So at the histology level, and again, regardless of the cause of nephritic syndrome or nephritis, and regardless of the cause of nephrotic syndrome, and by the way, from now we can tell you that it's really a spectrum of syndromes. So at one end starts the nephritic syndrome, and we'll talk about it in more details. At the other end stands the nephrotic syndrome. We'll talk about it in more details. But please keep in mind from now that all of this really constitute the spectrum of glomerulopathies that could be either itis, glomerulopathy meaning a disease that affects the glomerulus, obviously, that could have a sole manifestation of nephritis. We'll talk about it more, or the sole manifestation of nephrotic syndrome, and we'll talk about it. Or it could have a component of both. So there are certain diseases that we'll talk about later that will have a manifestation of nephritic syndrome, at the same time manifestation of nephrotic syndrome. And we'll talk about it. But for the sake of understanding and for simplifying the subject, let's talk about nephritic syndrome alone, like pure nephritic syndrome and pure nephrotic syndrome, and what characterize each one of them. So at the histology level, this is again a schema of how the glomerulus look like. Remember I told you the glomerulus is composed of capillary loops that are tethered together by a matrix called the mesangium. And it turns out, regardless of the etiology of nephritic syndrome, what characterizes nephritic syndrome histologically is two things. First of all, mesangial deposition, what we see under the microscope, especially under the electron microscopy, that there are certain deposits that are present there in the mesangium. Now, those are the deposits that will trigger the inflammatory response that we will see in nephritis. And what causes these deposits, obviously, up until now, we don't know. And again, we like to believe it's like a part of autoimmunity. Why patients develop nephritic syndrome? Again, for a reason that we don't fully understand until now. It starts to form like some immune reaction against its own tissue. And therefore, we see these deposits present in the mesangium. And again, the mesangium is the matrix that tethers the capillary loop together, connect them together. And this is where the mesangium is. So the mesangium has the matrix itself plus mesangial cells. And what characterizes nephritic syndrome is the presence of deposits inside this mesangium. And as a result of that, these mesangial cells will start to undergo proliferation in response to the presence of these abnormal deposits in the mesangium. And therefore, what characterizes nephritic syndrome, regardless again of the etiology, is the presence of mesangial deposition as well as mesangial cell proliferation. This is nephritic syndrome. If we move to the other end of the spectrum of glomerulopathy and we talk about nephrotic syndrome, and again, two things characterize nephrotic syndrome. But here the process affects, in particular, I'm talking about nephrotic syndrome, the glomerular basement membrane. Now remember, this is a physio as well as chemical barrier that prevents protein from being leaked from inside the blood to the Bowman space, to the urinary space. And that physical barrier that is created by the presence of the glomerular basement membrane, normally, as I told you, proteins are kept inside the blood and they are not allowed to leak out in the urinary space, the Bowman's space, and then the pelvis, and then the ureter, and then out in the urine. So what really affects the ability of the kidney to keep the proteins, which are very important, obviously, to the homeostasis of the human body, is the intact glomerular basement membrane. And what we see histologically is that, first of all, that glomerular basement membrane is thickened, and again, thickened by the presence of immune deposit in it. And again, why does it happen? We don't know. And then another component that contributes to the barrier of the glomerular basement membrane is the presence of the so-called podocytes, which is the epithelial cells covering the glomerular basement membrane. So remember here we have two issues that are seen histologically, and the same here we have two issues that will lead to the abnormality in the function of the glomerular basement membrane, and therefore the leakage of the protein in the urine. That is the thickening of the glomerular basement membrane, number one. And number two, you can see that there are slits between those legs of the podocytes. And when you see those being fused together, meaning that those podocytes are fused with each other, then this is the other histological manifestation of nephrotic syndrome, again, regardless of what's causing nephrotic syndrome. So the summary of histological finding: mesangial deposition, mesangial cell proliferation for nephritic syndrome, thickening of the glomerular basement membrane, as well as the fusion of podocyte for the nephrotic syndrome. And remember that we're talking about a spectrum. So you can have patients who have a component of itis and a component of osis. So they have the combination of these two features. This is histologically. I'm going to pause at some point and then open the floor for questions. So this is at the histological level. Now, when we talk about the clinical presentation, clinical phenotypes, And again, it's a spectrum similar to the histological spectrum of glomerulopathies. At one end stands the nephritic syndrome, at the other end stands the nephrotic syndrome. Now, if you have pure nephritic syndrome, we've already talked about the histological findings. Now, clinically, the way they present with hematuria. Now, this hematuria can be microscopic, meaning that you only see it when you examine the urine for whatever reason under the microscope, or it could be gross or macroscopic, meaning the patient will complain of hematuria, and he will tell you that I have a tea-colored urine or a Coca-Cola-colored urine. So the hematuria will be clinically evident by the patient himself. So keep in mind that hematuria can be microscopic or macroscopic. Now, in addition to hematuria, some patients who present with severe nephritic syndrome can have, in addition to hematuria, hypertension, renal insufficiency, and edema. Now, if we move to the other end of the spectrum, what is the clinical phenotype or clinical presentation of nephrotic syndrome? Remember, in nephrotic syndrome, we're talking about heavy leakage of protein from the blood through the glomerulus of the kidney to the urine. And therefore, the manifestation of it, obviously, is you have the presence of heavy proteinuria, operationally defined as more than 3.5 grams in 24 hours of urine collection. As a direct result of this, you have hypoalbuminemia. So the albumin, which is the most important protein in the blood, will decrease in concentration. Now, since the liver will try to compensate for the low protein by producing more protein, at the same time, the machinery of the liver will produce more lipids, and therefore you have hyperlipidemia in the context of heavy nephrotic syndrome. And finally, obviously, because the oncotic pressure of the blood is decreased, the clinical manifestation that the patient will complain from is the presence of edema, whether peripherally, like peripheral edema, or whether ascites, if he has a collection of fluid inside the abdomen. Okay, so, and again, if you have a component of both, you will see component of both. So if you have pure nephritic syndrome, these are the manifestation. If you have nephrotic syndrome, this is the manifestation. But if some patients will have a component of itis, as I told you, and osis, and therefore they will have a constellation of some of these and some of that. Finally, before I pause and give you time to ask questions, it turns out that examining the urine will extremely help you in making the correct diagnosis in these two syndromes, nephritis or nephrosis. Now, remember, I told you two histological markers of nephritis and osis, the same. When you examine the urine, there are two things that, if present, you can make the diagnosis with 100%, almost 100% certainty. For nephritic syndrome, we're talking about dysmorphic red blood cells and the presence of red blood cell casts. And for nephrotic syndrome, we are talking about lipiduria or fatty casts. And we'll show you an example of each in just a minute. So let's sum up and just remind you. So nephrotic syndrome is part of a spectrum. The clinical phenotypes are hematuria, plus, in severe cases, hypertension, renal insufficiency, and edema. For nephrotic syndrome, heavy proteinuria with low albumin, hyperlipidemia, and edema. And when you examine the urine, the two diagnostic features in nephrotic syndrome are dysmorphic RBCs and the presence of red blood cell cast. We'll show an example in just a minute. And for nephrotic syndrome, the lipiduria and fatty casts. Just to show you how the thing look like, just for fun, and just to keep this in mind, this is the way normal red blood cells look like. This is like showing normal red blood cells and normal white blood cell, how they look under the microscope. Please compare that with what you see here, for example. This is a phase contrast microscopy. When we talk about dysmorphic RBC, this is the way they look like. Look at this RBC, the budding small component of it at the periphery. Look at this one. Look at that one right here. How dysmorphic? Meaning that basically it has abnormal shape as compared with a normal shape of red blood cells. And the reason they assume this abnormal shape, remember the blood that you see in the urine in this case is a blood that had to seep through the glomerulus, meaning it has to leave the glomerulus from within, travel through the glomerular basement membrane and move to the Bowman space. And as it travels through the GBM, it gets dysmorphic, it gets disfigured. And that's why you have this dysmorphic red blood cells in nephrotic syndrome. This is like more enlarged three-dimensional view. You can see how dysmorphic these RBCs are. Look at this one, look at this one, look at this one, and that one. So this is, again, a characteristic feature of nephrotic syndrome, meaning that the hematuria that you see in this case is not coming from the pelvis of the kidney or from the ureter of the kidney or from the bladder of the kidney. It's coming from blood that had to penetrate through the glomerulus because of damage that affected the glomerulus and then shows up in the blood, and the RBCs would be quite dysmorphic. The other feature that is, again, sine qua non of nephrotic syndrome, and it needs an expert to diagnose it, is the presence of red blood cell cast. And the red blood cell cast is very simply a hyaline cast. It's a proteinaceous material that any one of us, if you examine your urine or my urine, anybody's urine, normally, they have normal hyaline cast. It's simply proteinaceous material that takes the form of a cast like this. But the only difference here, this hyaline cast is embedded with red blood cells. As you can see, all of these are red blood cells filling that cast, the so-called red blood cell cast of nephrotic syndrome. Now, remember I told you the presence of hematuria is not in itself diagnostic of glomerulonephritis or nephritis, because hematuria can come from a variety of reasons. If you look at this slide that I skipped quickly, there could be a pathology affecting the ureter of the kidney or the pelvis of the kidney or the bladder of the kidney, examples like stones, like UTI, like cancer. Any of that can cause hematuria. But the differentiating feature of hematuria caused by nephrotic syndrome, as I told you, is the presence of dysmorphic RBCs and the presence of RBC cast. And in addition, if this might be a question that will come frequently, how do you differentiate between a bleeding or hematuria that obviously shows up in the urine, whether that hematuria is coming from the glomerulus, like the example of nephrotic syndrome, or coming from extraglomerulus, like from anywhere from the pelvis of the kidney to the ureter to the bladder. These are some of the features that can help you to differentiate, listed in the slides. In general, when the patient complains of macroscopic hematuria, he will tell you if that bleeding happens to be not from within the kidney, the blood will be either red or pink, while here he will complain of it will look like tea colored or smoky brown or Coca-Cola type colored. Generally, if the bleeding happens to be in the glomerulus, there is no clot associated with hematuria. Here it might be present, especially if the patient has cancer. Proteinuria usually is very minimal if the blood happens to occur from extraglomerular part versus glomerulonephritis. But as I told you, the most important differentiating feature is when you look at the urine microscopy and you see the dysmorphic RBCs that I showed you, as well as the presence of RBC casts. This is the hyaline cast that I showed you, that I mentioned earlier. This is normally present in any urine. It's like a proteinaceous material, especially if the patient or if the normal human being does not drink too much water and there is a low flow state of urine output. This is formed, and this is the way it looks under the microscope, and its presence is normal. But when this hyaline cast is filled with RBC, like the example I showed you earlier, this is the RBC cast that we talk about. Now, so this is the nephrotic syndrome that we talked about, and we showed you the two most important diagnostic features of hematuria, the presence of dysmorphic RBCs as well as RBC casts. Now, if we move to the other end of the spectrum, and what we see in the urine microscopy in nephrotic syndrome, this is what we see. This is the same hyaline cast that I showed you earlier, similar to this one, But now, instead of being filled with RBC, like in the case of nephrotic syndrome, it's filled with so-called fatty droplets. You can see all of these are fat droplets. This is the way they look like under the light microscopy. And when you use a specialized form of microscopy called polarized, you can polarize these. This is the way they look like under polarized microscopy. This is the hyaline cast that I showed you earlier, having many fat droplets in it, the so-called fatty cast. And when you polarize the light of the microscope, it will appear similar to the so-called Maltese crosses, Sulban Fursan Malta, for those who speak Arabic. This is the way their crosses look like. It's like inverted V wave, like you have 4 V, letter V, meeting at the center and having equal dimension of the cross, like this way and that way, so-called Maltese crosses in the English literature. So this is the way the fatty droplets look like under the polarized microscopy. Right. Let me pause here and ask you if you have any questions about what has been mentioned thus far before we move to the next or second part of the lecture. Any questions about what has been mentioned?
No, doctor, thank you so much.
Right.
No, doctor, everything's clear. Thank you.
Right. Great. So we move to the second part now. So now we understand the histological features differentiating nephritic from nephrosis, nephrotic syndrome from nephrotic syndrome. We understand the clinical features, and we understand the difference in the unit microscopic finding between the two. And keep in mind, please, that again, we're not talking about, there are some patients who will have features of each, and that's why we like to talk about glomerulopathies as a spectrum, not as only one versus another. Similar to the, remember I told you about the hematuria, and not all hematuria that you see in clinical practice comes from nephritic syndrome. Hematuria could be caused by a variety of other things that we summarize briefly. Just keep in mind that anything that can affect the collecting system, whether infection, whether stones, whether neoplasm, can cause hematuria, and how to differentiate between hematuria caused by a glomerular hematuria like nephrotic syndrome versus hematuria caused by extraglomerular, meaning specifically anything in the urinary pelvis, urinary ureter, bladder, and urethra. Now, the same thing for proteinuria. Remember, I told you that proteinuria, usually that is caused by nephrotic syndrome, is heavy. We like to operationally define it as more than 3.5 grams in 24 hours. So this is how proteinuria caused by nephrotic syndrome occur. But there are a variety of other causes of proteinuria that you see listed in this slide. The most important thing to remember that nephrotic syndrome is associated with heavy proteinuria, meaning above 3.5 milligram. If you want to spend more time on trying to understand all of this, I think it's self-explanatory that proteinuria, the presence of proteinuria, does not almost always mean the presence of nephrotic syndrome. It highly suggests the presence of nephrotic syndrome if it's really heavy, defined as more than 3.5 grams in 24 hours. And if it's associated, obviously, with heavy proteinuria, which is the whole mark of clinical presentation of nephrotic syndrome, which is the presence of edema. And the edema in nephrotic syndrome is caused by the very low oncotic pressure, which is mainly exerted by the presence of albumin, which is the most important protein in plasma that gets depleted with heavy nephrotic syndrome. Now, before we talk about the different causes, what will help you after you obviously examine and being quite careful getting the right information from the patient. Now, the way they present sometimes will help you to narrow your differential diagnosis to certain entities. So thus far, we talked about what do we mean by nephritic syndrome? What do we mean by nephrotic syndrome? And what do we mean by the combination of both? And what's the histological and clinical manifestation and the urine microscopic findings? Now we'll move to how can we from other presenting features, we can narrow down the differential diagnosis of certain entities. Now, let me tell you from now that almost always, when we are faced with nephritic, a patient who presents with nephritic or nephrotic syndrome or both, we almost always resort to a kidney biopsy. So this is like a must in all cases. And the kidney biopsy is needed not only to make the diagnosis, but as well to prognosticate, to give some kind of prognosis in the context of deciding whether to treat whatever we see or not to treat. So a kidney biopsy is almost always necessary and needed in patients who present with nephritic or nephrotic syndrome. There might be a few exceptions here and there, but in general, it's needed. Now, remember I told you that if you talk about nephritis to start with, the hallmark of it is the presence of hematuria, be it microscopic, meaning you don't see it with your naked eyes when you examine the urine, when you look at the urine by naked eyes, but you see it only under the microscope, or the patients will present with gross or macroscopic hematuria. But regardless, if he presents only with hematuria and nothing else, this is what defines the so-called mild glomerulonephritis. Mild glomerulonephritis, meaning the patient presents with only hematuria and nothing else. Moderate to severe glomerulonephritis are patients who present with hematuria, but remember I told you with additional symptoms, meaning hypertension, renal insufficiency, and edema. So if the patient presents with only hematuria, whether gross or microscopic, that defines mild glomerulonephritis. If the patient presents with that plus the constellation of hypertension, renal insufficiency, or edema, that defines moderate glomerulonephritis. And that separation between the two entities is important because, as you can see, the differential diagnosis might be a bit different. Let's go through that very quickly to show you how that might help. So, patient present with hematuria only, let's say gross hematuria, and there's nothing else with it. Now, depending on the age of presentation, the differential diagnosis will vary. For example, patient present with only hematuria, he has mild glomerulonephritis. If he happens to be 15 years of age and less, the three entities or four entities that we worry about is mild post-infectious glomerulonephritis, IgA nephropathy, thin GBM disease, and hereditary nephritis. Okay, so this, I guess, for you to look like smart when you talk about nephritis, if your patient presents with mild glomerulonephritis, meaning only hematuria, nothing else, and happens to be 15 years of age and less, those are the four major entities that we talk about, and you would be right in more than 99% of the time if you make that, because eventually, as I told you, we resort to kidney biopsy to establish diagnosis. If your patient happens to be between 15 and 40, then, and present again with only mild glomerulonephritis, IgA nephropathy, thin GBM disease, lupus, and hereditary nephritis. Lupus becomes an important issue in this age group. And lupus, by the way, lupus is one disease. If somebody asks you about this, lupus is a disease that can present with nephritis only, can present with nephrosis only. Frequently, it presents with both. So the patient with lupus will have features of both nephritic and nephrotic syndrome. This is a good example why the spectrum is important to think about, because patients with lupus can present with features of nephritic and at the same time features of nephrotic syndrome. Now, if the patient happens to be more than age of 40, then you will be almost always right in making diagnosis as IgA nephropathy, almost always. So if somebody asks you, I have a patient who's 40 years of age, presents with gross hematuria and nothing else, he has normal kidney function, he has normal blood pressure and no edema, then you'll be right very close to 99% of the time in saying this is most definitely IgA nephropathy. Now, if we move to the other component of the clinical presentation, which is hematuria, whether gross or microscopic, but with features like hypertension, edema, and renal insufficiency, then again, the differential diagnosis will vary depending on the age of presentation. If it happens to be 15 and less, remember here, we're still talking about post-infectious. And by the way, post-infectious, as you can see, can present with mild disease or can present with severe disease. So some of you might keep in mind that post-infectious glomerulonephritis is benign, mild disease. Not necessarily. It can present with severe form of glomerulonephritis, and that's why you can see it listed there and here as well. And here we talk about another entity, the membranoproliferative glomerulonephritis, that could affect young age group. If the age of presentation happens to be 15 to 40, again, post-infectious glomerulonephritis is there. Lupus, again, is a very important entity to think about. But one thing that probably might be a question for you is the so-called rapidly progressive glomerulonephritis. It's very important to think about this if the age of presentation happens to be between 15 and 40, and especially above 40, as you can see in the third category. So this is a dreadful disease that, as the name implies, rapidly progressive, meaning the patient, if you see him today with certain kidney function, within a few days, you'll see his creatinine going up significantly from this entity, and can lead to really very quick destruction of the kidney and the need for dialysis within a few days, sometimes a couple of weeks or so. So hence the rapid diagnosis is really needed, and the quick institution of therapy is very important. So if you happen to have somebody in this age group, 15 to 40 or above the age of 40, think about rapidly progressive glomerulonephritis if they present with severe or moderate to severe glomerulonephritis, meaning hematuria with the other features that we talk about. Finally, for nephrotic syndrome, there's nothing called like mild or moderate to severe. Nephrotic syndrome is again, the hallmark of the disease is the presence of heavy proteinuria as defined, more than 3.5 grams of protein. And the way to narrow your differential diagnosis, again, the age of presentation is important. If the patient presents with nephrotic syndrome and happens to be 15 years of age and less, we worry about minimal change disease, focal and segmental glomerulosclerosis, mesangial-proliferative glomerulonephritis. Those are the three entities that you'll be almost always right in making the diagnosis, and the kidney biopsy will help you to say this is minimal change disease or FSGS or mesangial-proliferative glomerulonephritis. If the patient presents with nephrotic syndrome and happens to be 15 to 40, again, in our country, FSGS is one of the most common causes of nephrotic syndrome that you have to keep in mind. And it has some familial tendency in some of the patients, so there's a strong family history in some of them. But in addition, minimal change disease and now membranous will kick in as a potential differential diagnosis if the patient happens to be 15 to 40. If the patient is more than 40 years of age, remember seeing FSGS. FSGS, you see it here. If the patient is less than 15, you see it here. If the patient happens to be 15 to 40, and you see it again if the patient is 40 and above. So FSGS is really very important entity to keep in mind for patients who present with nephrotic syndrome, especially in the kingdom. So it's really quite prevalent. What comes next after it for this age group of above the age of 40 is membranous. So keep in mind membranous. Now, what is really quite common, and usually you don't have to worry about it because patients, you know from the history that he has diabetes. So nephrotic syndrome is part of the clinical manifestation of diabetic nephropathy at some point in time. But usually the patient will have years of history of diabetes. So you will see diabetes clearly evident in that patient well before he presents with proteinuria, heavy proteinuria. So keep in mind that diabetic nephropathy is an important cause of nephrotic syndrome. And the rest you can see it here. Now, if the patient happens to present with nephrotic syndrome at a very advanced age, like 60 and 70 and above, then at that point in time, you worry about amyloidosis and multiple myeloma causing the nephrotic syndrome. So keep that in mind. Nephrotic syndrome presenting above the age of 60 or 70 for the first time. He never had nephrotic syndrome before and obviously did not have diabetes. Worry about multiple myeloma as well as amyloidosis as the cause of his nephrotic syndrome. Now, to support your clinical impression, remember, this is how do you narrow your differential diagnosis based on the age of presentation, and in the case of nephrotic syndrome, whether the patient is presenting with mild or severe nephrotic syndrome. Additionally, we depend many times on certain blood tests that we order in the case of nephrotic syndrome as well as nephrotic syndrome. You all know why we do ANA and complements, mainly for lupus and post-infectious, and the same is ASO. Blood cultures, because septicemia can be associated with nephritis. ANCA and anti-GBM, mainly for rapidly progressive glomerulonephritis. Cryoglobulinemia, because again, mixed cryoglobulinemia can be associated with nephritis, glomerulonephritis. In the old days, before the development of vaccination for hepatitis B, and up until now with hepatitis C, we can see nephritic syndrome as part of hepatitis B virus and C virus infection. So keep those in mind. As we move to the end of the spectrum, when we talk about nephrotic syndrome, again, remember I told you that lupus, you can see it here with nephrotic syndrome, you can see it here with nephritic syndrome, and you can see it in the middle with patients presenting with feature of nephritic and nephrotic syndrome. So lupus is an important entity, but lupus is like diabetes. At least you will know that the patient has lupus ahead of time before he presents with either nephritic syndrome or nephrotic syndrome in general. So at least the diagnosis is easy when the patient has lupus or diabetes. You know upfront that you have a patient who was diagnosed with lupus, and now he has or she has evidence of nephritis or oocysts. Serum protein electrophoresis to look for the immunoglobulin spike in the immunoglobulin. Looking for evidence of multiple myeloma and so on. Hepatitis B and C serology are both, again, more C than B, because now we almost eradicated hepatitis B virus infection. Is not as common as it used to be in the old days with the effective hepatitis B vaccine. HIV serology remains an important issue because, unfortunately, we see a very severe form of FSGS, collapsing FSGS with HIV infection. So keep that in mind. In the old days, syphilis serology, syphilis used to be associated with nephrotic syndrome. We don't see much of it nowadays. So those are the main blood tests that we order for nephrotic syndrome, and those are the tests that we order for nephritic syndrome. Any question thus far?
No, doctor.
No, doctor.
No, doctor. All good.
Very good. Okay. So this is an example. Remember, I showed you earlier how the normal glomerulus look like under the microscope. This is an example of post-infectious glomerulonephritis. Just give the schema in your mind how the glomerulus is enlarged. As you can see, this is much larger than the initial picture I showed you. And you can see all of these dots, black dots, are inflammatory cells within the mesangium. And remember, I told you that histologically, the most important features, the two most important features of what you see histologically are the presence of mesangial deposits that will lead to this inflammation and the proliferation of the mesangial cells. And that's the reason the glomerulus is enlarged, because of the proliferation of the mesangial cells, as well as the intense inflammatory infiltration of these inflammatory cells in the mesangium. Now, I'm sure you have heard the talk about acute kidney injury. Somebody presented it earlier, or I don't know if it will be presented after my talk. Regardless, acute kidney injury is an important topic for you to understand. But in the context of glomerulonephritis, you can see it in association with nephrotic syndrome in particular. And this is important for something for you to know, that patient with nephrotic syndrome, remember, I didn't tell you about anything that has to do with abnormal kidney function. They present with proteinuria and edema. That's it. But the kidney function in many of them remains normal. But in this case, sometimes they present with acute kidney injury on top of their nephrotic syndrome. And you can see it with minimal change disease. You can see it with FSGS. So keep that in mind, that some patient with nephrotic syndrome can present with acute kidney injury, and probably whoever's going to present about acute kidney injury can highlight this for you. But at least for now, remember that patients with nephrotic syndrome can present with acute kidney injury, and the most important example to remember are patients with minimal change disease as well as patients with FSGS. Finally, the family history is important in some of these glomerulopathies, and it will help you as well in the final narrowing of your differential diagnosis. For example, thin GBM disease is often familial disorder. with autosomal dominant inheritance. So having a clear family history will be important for you to get as part of your history and physical. Hereditary nephritis, especially Alport nephritis, as well as the familial history is important. I told you about the FSGS, especially in the kingdom. It's probably one of the most prevalent glomerulopathy in the kingdom, and definitely in some families there is really clusters of cases, and both autosomal dominant and autosomal recessive transmission has been reported in families in the kingdom. This is for the family history. Now, when you have, in addition to nephritis presentation, meaning hematuria, if you have pulmonary features with it, so if a patient presents with the features of nephrotic syndrome, as I mentioned to you, but in addition has some pulmonary manifestation, and again, that will narrow your differential diagnosis to a few things that can cause it. Those are the three things that can be associated with pulmonary manifestation, meaning patient present with classic features of nephrotic syndrome, but in addition, he has pulmonary features. The first one is obviously the Wagner type rapidly progressive glomerulonephritis, or the vasculitis component of ANCA. Both can present with both nephrotic syndrome and pulmonary manifestation. The one that you probably remember or you read about extensively is the Goodpasture syndrome, which is the anti-GBM disease. And again, it's nephritis along with pulmonary manifestation. So patient present with hematuria and hemoptysis at the same time. So blood in the lung as well as blood in the urine. And that's what anti-GBM is about. And don't forget that lupus as well. So if you want to remember three entities that can be associated with both glomerulonephritis as well as pulmonary manifestation, the ANCA, the Goodpasture syndrome, and the lupus. Those are the three entities. And if the hematuria happens to be unique, meaning that it happens only after the patient develops upper respiratory tract infection, those are the four entities that you think about. If the patient, after you get a careful history, tells you that I get the hematuria only after I get recent attack of upper respiratory tract infection, that can happen only with IgA nephropathy, C3 glomerulonephritis. This is a newly described entity, but I think if you remember IgA nephropathy, Alport syndrome, and thin GBM disease, that will really be enough. When the hematuria in particular occurs only after an episode of upper respiratory tract infection. So what I thought I'll do for you today, I mean, just to give you really the basis of itis and osis and how to understand it histologically, clinically, how to differentiate, what are the differentiating features of each one of them. And it's not really meant for you to talk about the management, how to manage, because as I told you, it all depends on what we see on the kidney biopsy. First of all, to establish what caused nephritic syndrome or nephrotic syndrome or both of them, sometimes at the same time, and how badly the kidney is damaged, because many of the treatment that we use for these entities are really heavy immunosuppression that will have certain complications. So we don't use it unless we are sure that the patient is still early in the process of his disease and the kidney is not like damaged extensively from whatever has happened earlier with fibrosis, tubular atrophy, and so on. And I don't think at your level it's important for you to understand the different therapeutic modalities that we use, but at least if conceptually, if you understand the basic difference between itis, glomerulonephritis, and nephrotic syndrome. So that's the end of the lecture. If you have any questions, please let me know. Any questions about anything has been mentioned?
Thank you, doctor.
No, doctor, everything's clear. Thank you so much.
Okay, very good. Thank you very much. Good luck to you.